Good evening. This is Dr. Mubarak Ad-Dosari on behalf of the East Mediterranean chapter of International League Against Epilepsy. I welcome you today to the Epilepsy Educational Webinars. Our topic today, focal features in generalized seizure, a diagnostic challenge by Dr. Amal Al-Muhawwas. Dr. Al-Muhawwas is a consultant adult neurology and epilepsy. She is a program director of adult neurology residency training program at Armed Force Hospitals in the Ministry of Defense, Dhahran, Saudi Arabia. Dr. Al-Muhawwas obtained her clinical fellowship training in epilepsy and EEG in the University of Calgary, Canada between July 2018 and June 2019. Kindly, if you have any questions regarding the lecture, feel free to write it down in the chat and we will get back to it later on. Welcome, Dr. Amal Al-Muhawwas, and the mic is yours.
Assalamu alaikum. Good evening, everyone. Thank you, Dr. Dosari, for this introduction. It's an honor to be with you today. I would like in the beginning to thank the team of International League Against Epilepsy, in particular Dr. Raida, for giving me the chance and to present today. Thank you, Jessica and Gus, for being for fixing everything technical to give us a good shape here in this presentation. Inshallah, we'll spend good time with in this presentation, and I think we can start. I hope this will be an easy subject to digest today and won't be confusing for anyone. Nothing to disclose. We'll try in my presentation to cover the following objectives: the prevalence of these focal features, their common presentations, and the impact of these focal features on therapeutic response. We'll try to cover most of the update in the literature review. We'll spend some time on the special entity called generalized onset seizures with focal evolution, which is called GOFI, and we'll end up with the decision flowchart that can help us in deciding about these cases. To start with, the history of these focal seizures is nothing new. This was really described in the literature since 1959 by O'Brien group. Reviewing the literature from that time until 2014, it can be explained by four possible explanations. First one is misdiagnosis of focal epilepsy as idiopathic generalized epilepsy due to poor diagnostic criteria. Focal features as an integral component of idiopathic generalized epilepsy compatible with that diagnosis, or the coexistence of both idiopathic generalized epilepsy and focal epilepsy, generalized seizures in idiopathic generalized epilepsy having a focal onset. And we'll try to explain these four categories, whether these are applicable in the recent days and in the literature review. For the first one, misdiagnosis of focal epilepsy as idiopathic generalized epilepsy due to poor diagnostic criteria. This can be related to poor case selection with imprecise diagnostic criteria that may result in the inclusion of focal epilepsy cases in idiopathic generalized epilepsy study cohort, and one might interpret focal features on that basis. But we know that most studies from tertiary centers have included patients based on established International League Against Epilepsy criteria, and we think that this category does not appear to be a major confounding factor after the update in the criteria. For the next category is the focal features as an integral component of idiopathic generalized epilepsy compatible with that diagnosis. We know that studies indicate that the presence of these focal features is not incompatible with the diagnosis of idiopathic generalized epilepsy, and focal abnormalities are caused by the impact of repetitive seizure activity, could be effect of anti-seizure medications, or even genetic factors. What about the coexistence of both generalized and focal epilepsy? We have case reports and case series describing coexistence of proven focal epilepsy and well-characterized idiopathic generalized epilepsy in the same patient. However, this phenomenon appears to be rare, accounting for less than 1% of the idiopathic generalized epilepsy population in the studies. Given the tertiary center referrals bias, the true prevalence is likely to be even smaller. Hence, this phenomenon is unlikely to be responsible for all the focal features of idiopathic generalized epilepsy reported in the studies. For generalized seizures in idiopathic generalized epilepsy having a focal onset, we know that the key feature is origin within the rapid engagement of bilateral networks in generalized seizures, as opposed to origin within network limited to one hemisphere in focal seizures. And this is very well known in the recent International League Against Epilepsy reports. Most studies shows involvement of both the thalamus and cortex in relation to generalized Baken-White discharges. Although the relative importance of each component is less clear, at least two EEG functional MRI studies have shown bold activity in the frontal cortex before thalamic activation, which could be interpreted as evidence supporting the cortical focus theory. And we know that cortical focus theory, one of the most recently proposed to indicate the origin of generalized spike wave discharges in a frontal cortical focus. And it is important in this category to distinguish cortical onset of generalized spike wave discharges in the generalized epilepsy from focal frontal lobe epilepsy with rapid generalization based on a thorough assessment, which include clinical details, neuroimaging, and EEG. So these can explain the four explanations that were thought in the previous studies, but most of these are now not applicable after having the International League Against Epilepsy definition of the idiopathic generalized epilepsy syndromes, the position statement that was published 2022, which indicate that focal features should be red flags and alert the clinician regarding the diagnosis or even exclude idiopathic generalized epilepsy. And according to the position paper, a consistent unifocal semiology at seizure onset can rarely be seen, and consistent focal EEG patterns are considered as exclusive criteria for juvenile absence, juvenile myoclonic epilepsies, and generalized tonic-clonic seizures alone. Now, moving to the most common focal features in generalized tonic-clonic seizure, and I think most of you, as a neurologist or epileptologist, have been exposed to these focal features. The most common one, accounting for 66%, is the forced head version, followed by the unilateral myoclonic jerks. We have also figure of 4 sign, asymmetric seizure terminations in 41%, lateralized gesture automatism typically seen in ipsilateral temporal lobe focus, lateralized limb automatism seen in 11% of absence seizure, unilateral myoclonic jerk, as we mentioned, post-ictal nose wiping and hemiparesis in 10%, and aphasia in 15.6%. For the focal interictal discharges in generalized tonic-clonic seizure, these can be distributed in both hemispheres or multifocal. Unilateral interictal discharges reported by Lombroso group, and they reported that 56% of 58 patients with idiopathic generalized epilepsy who had multiple EEG recordings had consistent focal features in 65% of the EEGs, which is a quite good number. And these focal discharges can be ictal or interictal abnormalities. For the focal interictal EEG abnormalities in generalized epilepsy, as you can see here, the selected cases reported the occurrence of focal interictal abnormalities in 14 to 56% of the patient, And most of these studies reported the frequency of independent focal epileptiform activities, which were mimicking the focal epilepsy, occurring in 7 to 35% of the patients, as you can see in the right side of this table. The occurrence of these abnormalities was variable among different studies, as you can see in the graph below. This variability is probably related to difference in the length of EEG recording. We know that the longer the recording, the most likely to capture a particular abnormality, and the threshold set by each reader who classifies a waveform as epileptiform. For the focal ictal EEG abnormalities in generalized epilepsy, we have really a limited number of studies exist in the area of focal abnormalities. I chose for you here in this top presentation today 3 selected studies that are utilizing video EEG monitoring, and the first one is by the group Yushi, who studied 26 patients with juvenile myoclonic epilepsy. The diagnosis was based on the result of ictal and interictal video EEG recording. 3 patients, which account for 11%, exhibited lateralized ictal activity during generalized tonic-clonic seizures. Their initial EEG seizure patterns were generalized, but after a few seconds, paroxysmal alpha waves lateralized to one hemisphere. In these patients, if a focal symptom like a head version occurred, this symptom was contralateral to the lateralized paroxysmal activity. The second study by Ojani group, who analyzed 302 myoclonic seizures in 5 patients with juvenile myoclonic epilepsy using a video EEG. His group used the criteria of JME by Wolf, 1992. The asymmetry of myoclonic jerks were noticed in 4 out of 5 patients. Predominance of one side or the other was variable. They described patients who reported unilateral myoclonic jerks, but indeed these jerks had bilateral myoclonic jerks when analyzed on video EEG. The third study by Lenane group, he reported 6 patients, all with idiopathic generalized epilepsy with the similar lateralized ictal EEG findings correlating with contralateral focal symptoms like the head version or fencing posturing. And the diagnosis of idiopathic generalized epilepsy was reached based on epilepsy characteristic and risk factors, brain MRI results, neurologic examinations, ictal and interictal EEG tracing, as well as video recorded semiology. And this will take us to the special entity, which is GOFI, genetic generalized epilepsy and generalized onset seizures with focal evolution. This is considered under-recognized seizure type, defined by an evolution from generalized onset to focal activity during the same ictal event. It presents many similarities to the genetic generalized epilepsy. Recognition could bring therapeutic interest, avoiding misdiagnosis of focal epilepsy, and consequently inappropriate use of narrow-spectrum anti-seizure medications. Also, we have limited studies that studied GOFI. As you can see here in the right side of the table is the last group that we discussed, Lenane group, who studied 6 patients. For the LAMI group, who reported these patients in 2022, they have 51 patients with adult or adolescent onset epilepsy, recorded seizures in the tertiary center between 2011 and 2021. 45 patients presented with focal epilepsy, 3 patients with the genetic generalized epilepsy, 3 with seizure of unknown etiology that corresponded to the GOFI entity definition. And these are the 3 patients listed in this table. These 3 patients were initially referred for video EEG monitoring because of persistent or worsening seizure. The mean age, as you can see here, is the mean age of seizure onset was 18 years, ranging from 13 to 22 years. There was no personal history of epilepsy or risk factors for epilepsy. Mother of patient 1 had history of familial seizure. Neurological examination and cerebral MRI were normal. The total of seizure captured, 4 GOFI seizures were recorded during the video EEG monitoring. There were 2 for patient 1 and 1 for patient 2 and 3. They all presented with generalized interictal discharges when awake and during sleep, without focal interictal abnormalities. And these GOFI seizures were characterized by 2 to 3 seconds of generalized abnormalities, followed by focal evolution of discharge that I will show you in the next figure. The semiology at generalized EEG onset consisted of behavioral arrest in the 3 patients, and they all presented focal clinical features during focal ictal phase with head and ocular version, or with figure 4 sign, and all listed here. Genetic screening in patient 1 and 2 was negative. All had normal intellectual development. Despite the initial uncontrolled seizure, the 3 patients became seizure-free. Patient 1 and 2 after discontinuation of lamotrigine and addition of valproate. Patient number 3 following increased dose of dibakine. This is the EEG recording of patient, the first patient, patient number 1 in the table. This is a bipolar longitudinal montage. The total seizure recorded was 1 minute 40 seconds. In figure 8, this showed the ictal onset with asymmetric 2.5 hertz, generalized spike and wave discharges. In B and C, you can see the focal evolution with widespread left discharges, and then here it shows when the seizure ends. Now moving to the focal ictal semiological finding in generalized epilepsy. This is a summary of selected studies that shows the percentage of patients with 3 different focal ictal symptoms mimicking lateralizing sign during generalized tonic-clonic or generalized clonic seizures. And you can see here is the Friziev component, figure of 4, and focal clonic or tonic component. The next one showed the result of a study by Niaz group, which illustrate focal symptomatology in bilateral tonic-clonic seizures in generalized versus focal epilepsy. Whether it is a focal clonic or tonic seizure, Friziev maneuver, asymmetric tonic or asymmetric or asynchronous clonic phase. This table showed you a summary of selected studies that shows the percentage of patients with different focal ictal symptoms, again mimicking the lateralizing sign during generalized tonic-clonic or generalized clonic seizures. And you can see the different percentage. It's the same, the graph that I showed you, listed in this group, in this table. There are other studies that have analyzed ictal symptomatology in patients with idiopathic generalized epilepsy, utilizing a more reliable method of video EEG. In general, the focal ictal findings on video EEG in patients with generalized epilepsy are focal myoclonus, virgin, figure of 4, sign, focal clonus, and asymmetric motor symptoms at the end of seizure. These focal ictal symptoms mimic lateralizing sign typically seen in focal epilepsies. Here are a few examples from the same study. samples of the interictal epileptiform activities from the same cases that were reported. You can see here the 3 Hertz generalized spike and wave discharges that are lasting for 5 seconds. And asymmetric. This one showed independent. You can see here in the blue circle, independent right, and the red one, the red circle showed a prominent left frontal sharp waves. Here you can see the interictal generalized burst of irregular spike and wave that also were recording the same EMU admission. You can see in figure A the burst of generalized spike and wave. And if you follow this vertical blue line, which indicate the absence of leading point, and these abnormalities are sometimes asymmetric with the lid in over the right hemisphere, as you can see here in the in figure B, that is indicated by the red line, or sometimes over the left hemisphere, as you can see here, indicated by the vertical green line. More examples from the same cases. These epochs showing a generalized seizure. Figure A showed the generalized the seizure onset. The pattern is generalized at the onset, as you can see, as indicated here by the bracket. Posterior dominant rhythm, as you can see here, before the seizure onset. In figure B is the seizure evolution. The seizure evolution was 15 seconds after the onset of the generalized electrographic seizure. You can appreciate the monomorphic regular bifrontal rhythmic delta. And better recognized in the first 5 seconds of this page, that give way to theta alpha frequency activity, as you can see here, like the sawtooth appearance in the right posterior head region. This activity, as you can see, spread to the both hemispheres toward the end of the page. And in addition, the EKG shows involvement of the muscle of the torso during the last 3 seconds of the page. The same seizure following here, this shows you the end of the seizure with the bilateral discharges, as you can see here in the right hemisphere, probably higher over the left hemisphere, which is likely producing a time-locked EMG artifact over the right hemisphere electrodes. The EEG also electrodes on the right have overriding EMG artifacts of frontalis and occipitalis muscle. The unilateral EMG artifact correlate with the asymmetric end of seizure clonic movement, as you can see here, very time-locked. And after the end of the seizure, there is a generalized suppression of the background activity corresponding to the post-ictal state. Moving now to the recent update in this topic, and this is I found the recent update in the literature, which is published and reported by Valchow group. I hope I pronounced that in a correct way. He reported, or he did a 2-step retrospective observational study of patients with generalized tonic-clonic or focal bilateral tonic-clonic seizures that admitted for long-term video EEG monitoring at the Danish Epilepsy Center. The patient inclusion criteria were diagnosis of idiopathic generalized epilepsy based on international against epilepsy classification guidelines, They have a follow-up at the center more than 1 year after diagnosis of their epilepsy, and more than or equal 1 generalized tonic-clonic seizure recorded on video EEG. A summary of these patients, a total of 18 patients, as you can see here. Females were 10 with idiopathic generalized epilepsy fulfilled inclusion criteria. All had a total of 24 GTCs. Patient mean age of epilepsy onset was 13.1. 2 patients had a family history of epilepsy, and none had previous febrile seizures. 2 patients suffered from depression. All patients had normal MRI. 8 patients had juvenile myoclonic epilepsy. 3 patients had idiopathic generalized epilepsy with GTCs alone, and 1 patient had juvenile absence epilepsy. This is mainly the demographic and clinical data of the 18 patients. Now moving to the semiological features of these 18 patients. The focal seizure semiology occurred during the generalized tonic-clonic seizure in 77.8% of the generalized seizure patient. And if you count the asymmetric seizure termination, when these asymmetric seizure termination were included, the proportion increased to 88.9%. As you can see here in the table, the most common lateralizing feature was head version, observed in 12 patients. Other lateralizing features were focal tonic, 22% of the patient, focal myoclonus around 5.6%, lateralized gestural automatism in 11.1%, figure of 4 also 11%, asymmetric seizure termination was seen in 27.8%. For the post-ictal clinical phenomena, it was not found in these patients. This is the continuation of the 18 patient with the same finding that we have discussed. Now, showing a few of their EEGs that were mentioned in the same study. This is showing the focal interictal epileptiform discharges in figure A in the common average montage. Here showing the same focal interictal discharges in a longitudinal bipolar montage. In C, showing a generalized interictal discharges in the common average montage and in a longitudinal one. Here is the ictal EEG. As you can see here, the generalized onset. You can observe the bilateral synchronous and symmetrical onset at the end of the second number 2 with the common average montage. In figure B, you can appreciate, I hope this is very clear for you, the focal onset, the build-up of spike and wave activity in F4, while background activity continues undisturbed during the first 3 seconds in F3. I hope this is clear for you. And moving to the next, this is the lateralized 7 Hertz activity during the propagation phase of the generalized onset tonic-clonic seizures. This is the summary of the focal EEG and semiological features in the idiopathic generalized epilepsy. As we mentioned, the percentage per patient of the focal one, the focal ictal pattern, and you can see that the focal onset is very rare, and the focal semiology as the numbers we mentioned before. The group in this recent study, they published they developed this decision flow chart based on multiple observation derived from their clinical experience prior to the study, which include patients with idiopathic generalized epilepsy that have bilateral synchronous interictal discharges with or without focal features that were recorded in the EMU, patient with bilateral synchronous ictal EEG onset of tonic-clonic seizures having idiopathic generalized epilepsy, and patient with bilateral tonic-clonic seizure who have bilateral synchronous interictal discharges but focal ictal EEG onset. What they did to assess the accuracy of their decision flow chart in distinguishing between focal and generalized epilepsy in patients with bilateral tonic-clonic seizures and focal electroclinic feature, they included and analyzed 42 consecutive patients with focal epilepsy who had bilateral tonic-clonic seizure in the EMU and who were age and sex matched in the idiopathic generalized group. They just follow this chart, and I think it's very clear, easy for everyone to follow with the type of the focal finding. They also applied this flowchart to 59 cases and controls, 17 with idiopathic generalized epilepsy and 42 with focal epilepsy. This flowchart correctly classified 57 patients. That accounts for accuracy of 96.6%, confidence interval of 88.3 to 99.6, sensitivity of 94.1%, which I think these are good numbers to depend on and to easy test the makes easy to use this flow chart in classifying patient. The other thing that was studied, whether there is an impact of these focal features on therapeutic response. And reviewing the literature, we this really entity is controversial. Some studies reported a less favorable outcome in idiopathic generalized epilepsy patient with focal findings. Other studies on specific idiopathic generalized epilepsy syndromes did not find association between focal features and therapeutic outcomes. The last publication, the group of Valchow group, showed the presence of focal EEG or semiology did not really affect therapeutic response in their study. The question is, why do we have these discordant results? It may reflect heterogeneity regarding the definition of focal signs among the studies. For example, the inclusion of amplitude asymmetry or focal EEG slowing may in some cases lead to overinterpretation or misclassification affecting the evaluation of outcome. Another reason, there is important heterogeneity in this studied population, comparing patients with different idiopathic generalized epilepsy syndromes, which may differ in terms of treatment response. The also choice of anti-seizure medication is also a crucial factor, as anti-seizure medication not recommended for generalized epilepsies may affect the prognosis. In addition, the studies examining focal semiological features of generalized tonic-clonic seizures in idiopathic generalized epilepsy based on video EEG often contain a limited number of patients, as capturing their GTCs in generalized epilepsy is rare. And I think this is the case scenario, the common one in our EMUs, that a referral of generalized epilepsy is very rare to the unit. The relatively small cohort may also contribute to the remarkable variability. And we know that in clinical practice, the challenging patients are those who report GTCs with focal semiology and have focal interictal discharges. Although patients with idiopathic generalized epilepsy and GTCs often have focal interictal discharges, the ictal onset rarely is focal, even in patients who have focal semiology. And this was tested very repeatedly in these studies. Awareness of the presence of focal electroclinical sign in idiopathic generalized epilepsy to avoid misclassification. The population size is relatively small because the rare occurrence in the EMU of GTCs in idiopathic generalized epilepsy patients. So at the end, we can summarize this really I'm not sure if it is a confusing topic or we wanted to make things easier. Focal semiology and interictal EEG are common in generalized tonic-clonic seizures and should not exclude idiopathic generalized epilepsy diagnosis. Focal ictal EEG onset of tonic-clonic seizures is rare in idiopathic generalized epilepsy, and when present, it points to different location than the interictal discharges. The most common semiological feature is forced head version. Presence of focal features in idiopathic generalized epilepsy does not seem to affect the patient's therapeutic response, and this is very important. The flowchart assisting concordance between interictal and ictal EEG localization accurately classifies these difficult cases, which can be of good help for us. Thank you very much for listening, and these are my references.
Thank you, Dr. Al-Mhawas. Fantastic talk. Personally, I enjoyed the webinar. I will open the floor for any questions. Please feel free to write down your question in Q&A or the chat bar, and we will be happy to answer it by Dr. Al-Mhawas.
I'm not sure, Dr. Mbarak, if everyone really digested the topic or it is so confusing that they don't have much
It's
questions.
very interesting, and I totally agree. It's challenging for us on the daily life because we don't see it always black and white. Always there is a gray zone when we talk about the seizure and localization. And I totally understand that sometimes we meet or encounter patient with a tricky presentation, and definitely it's one of the most important question: what type of epilepsy we are dealing with? So. I have a question here from Ahmed Saeed, how to differentiate between IGE, idiopathic generalized epilepsy, and BME, I think progressive myoclonic epilepsy, EEG similar at onset. So Dr. Al-Mhawas, he is asking how to differentiate between the idiopathic generalized epilepsy and progressive myoclonic epilepsy.
Well, I think the to differentiate, it's really nothing no one test to confirm that one. We know in epilepsy it's a general, it's a clinical history, it's the onset, it's the EEG finding for sure, it's the continuity of also EEG finding, it's the response of the treatment. It's not one test. In epilepsy, we know that as a neurologist and even epileptologist, it's just not one test. We have to complete all things together, cerebral MRI with clinical presentation, family history, the prognosis, the response to treatment even can help us.
Okay, perfect. So still we are waiting questions. Okay, so we will go back to one of the old questions, probably not related to the topic, but maybe we can answer them, Dr. Al-Muhawwas. Okay, so Ala Mufag asking here, what is the unilateral eye blink absence indicate in EEG? So if you get the question correctly, Dr. Al-Muhawwas.
Well, if she's talking about unilateral eye blinking, we know that we can see this in, it is associated with frontal temporal seizures onset, especially if it is like on the left side. But don't forget that eye blinking is one of the biggest contaminating signal and can be greatly hinder the interpretation of EEG. So again, EEG alone is not enough. We have to see the video EEG, this can also give maybe focal signs on the EEG, so we have to have video recorded on that one also.
Okay, sounds perfect. Dr. Al-Muhawwas, we have another question asking how EEG can definitely identify the type of seizure and how we can name the region of seizure by using EEG record.
Okay, so talking about scalp EEG, this will not help a lot. We know that it is like a helping confirmatory test, but maybe this question can be answered more with the video EEG monitoring. In difficult cases, that can go to depth electrode monitoring that can localize really the seizure if we are talking about epileptogenic zones. And if we talk about like focal findings, this is not, as you can see, the studies that I reviewed in the literature more goes with video EEG monitoring and not the scalp one. It's really difficult with the scalp EEG.
Apparently, we started to have more interesting questions. So we have another question. If generalized seizure was found to be with focal onset, do we need to use both for focal and generalized anti-seizure medication? Probably asking what type of anti-seizure medication we need to use, the broad spectrum or narrow spectrum?
Okay, to start with, having a coexistent focal and general type of seizure is very rare. So we have to confirm this finding first. And in these cases, we try our best to avoid the narrow spectrum one, like the lacosamide, pregabalin, let's say gabapentin, the narrow spectrum one. But we have to confirm the coexistence. It's really rare, even in the literature. Whether it is the clinical, the patient presenting with focal, and you can see generalized, and this is usually the common referral from general neurologist. I think even you, Dr. Mubarak, you receive these cases to be studied in the EMU that having both coexistent, but we find later this is a generalized with focal finding, and this is where the confusion start.
Okay. Also another interesting question asking how can we differentiate between the secondary bilateral synchrony, SBS, from the primary bilateral synchrony, which we see with the idiopathic generalized epilepsy or other generalized epilepsy syndromes?
If we're talking about, I think we need to have a longer EEG recordings. In our scalp EEG recording 30 to 40 minutes, sometimes it's difficult to differentiate. It's sometimes even rarely to see it. But with a longer duration, longer recording, video EEG monitoring, I think it's easily differentiated with the onset, the type of the bilateral involvement, the asymmetry, the amplitude measurement. We need longer duration, longer recording.
Okay. Thank you, Dr. Al-Muhawwas. I think we can conclude here. Fantastic webinar. I'm happy to attend and moderate this activity today. And I hope the audience enjoyed the talk. And again, thank you a lot, Dr. Al-Muhawwas. See you in next webinars.
Thank you very much. Thank you for everyone.